Okay, hello everyone, and welcome to the Melanoma Research Foundation Ask the Expert series. My name is Debbie Churgai. I am the Senior Education Program Manager at the Melanoma Research Foundation. Today, we are pleased to have you join us for this wonderful educational opportunity entitled What to Know About Combination Immunotherapy Treatment. Today, we will be discussing combo IO and why it's an important option in treating melanoma. During the webinar, we will explore how combo IO works and why it matters, highlights from recent clinical findings, emerging subcutaneous options, and how they might impact treatment delivery. Explained in a way for patients to feel empowered and educated. First, I would like to thank our sponsor, Bristol Myers Squibb. We are so grateful to them for their generous support of this webinar and investment in the MRF's mission in helping to educate and provide support to the patient community at large. Thank you, BMS. Just want to tell you, before we get started, just a little bit about the MRF. The Melanoma Research Foundation is the largest independent organization devoted to melanoma. Our mission is to eradicate melanoma by accelerating medical research while educating and advocating for the melanoma community. The MRF is committed to the support of medical research to develop effective treatments and eventually a cure for melanoma. We know that education is critical for patients to make informed decisions about their care. And we have many educational offerings, not only directed at patients, but we create education materials and events for caregivers, family members, and providers. Our educational literature is all free to download or order for print. You can order materials for health fairs, schools, conferences. We also send these materials to physician offices, dermatology offices all over the United States. We encourage you to take a look at our offerings and see if you want to order any for yourself or for your doctor. We also have 6 animated patient videos and actually 3 more currently in production. These videos are all less than 10 minutes long and pack in a lot of information with great visual images. If you have family or friends who want to learn more about melanoma, these are a great educational option to send to them that won't overwhelm them too much and that are very visually pleasing. Each year, the MRF also hosts a series of in-person educational events in partnership with major academic medical centers. These meetings provide an opportunity to learn from leaders in melanoma and network with other patients and caregivers. We just completed 4 symposia, and you can go back and watch them at any time. You can find those links under the events tab on our website or on our YouTube channel. We have 2 more that we are hosting in the fall. So if you live near Santa Monica, California, or Houston, Texas, please keep an eye out for more information on those soon. Hold on 1 second. Not only are all of our past symposia available on our YouTube channel, but we also have dozens of other educational offerings, including all these Ask the Expert webinar series. This one will be available on YouTube in a week or 2. And we have a melanoma educator course as well. We have a variety of patient and caregiver support services, such as patient and community forum, treatment center finder, financial assistant resources, and Ask the Nurse hotline. If you are looking for a clinical trial, the MRF is proud to partner with CareBox for our clinical trial finder. It connects patients with trials tailored to their specific diagnosis, ensuring they receive the most up-to-date care options available. Oops, sorry. Patients can connect with a clinical trial navigator and who can help you gather information regarding diagnosis, stage, and treatment history. provide information and connect details for trial matches, and help overcome barriers to access. Lastly, there are many opportunities to support the work of the MRF through a variety of programs. We also have events, research funding. Feel free to contact me or anyone at the MRF after this webinar to talk to us about ways you can engage in the melanoma community while investing in our shared mission. And the best way to learn more about the MRF and everything that I've mentioned today, including information about our education, advocacy, or research programs, awareness campaigns, and upcoming events, is to follow us on social media. And again, visit our website, melanoma.org, for more information. Okay, I just have a little bit of housekeeping that I want to take care of, and then I will send it over to Dr. Moser. But just give me 1 minute. Okay. Before we get started, we encourage you to use the Q&A box on your screen to ask questions throughout the session. We've already had a lot of questions have come in from the registration, but please feel free during the webinar to add more. The information presented during today's session is for educational purposes, and any individual treatment questions should be directed to your healthcare provider. We encourage everyone to visit melanoma.org to learn more about the resources we have available. Now I'd like to introduce you to our expert for the evening, Dr. Justin Moser. Dr. Moser is an associate clinical investigator in the Cancer Research Division at HonorHealth Research Institute. He also serves as a clinical assistant professor at the University of Arizona College of Medicine in Phoenix, and adjunct faculty at the Translational Genomics Research Institute, part of City of Hope. He completed a drug development scholarship at HonorHealth, a hematology oncology fellowship at the University of Utah's Huntsman Cancer Institute, and an internal medicine residency at Mayo Clinic in Rochester, Minnesota. Dr. Moser has served as principal investigator on more than 20 clinical trials, published extensively, and presented research at national conferences. He has received multiple honors for research and leadership, including awards from the Arizona Clinical Oncology Society and the Huntsman Cancer Institute, and we are honored to have him present for you today. Dr. Moser, take it over.
Well, thank you for the kind introduction. So let me go ahead and pull up my slides. Okay. So can everyone see the slides? Is that coming through? Perfect. So like Debbie stated, I'm Dr. Moser. I'm a medical oncologist here in Scottsdale, Arizona, and I'm part of HonorHealth Research Institute and also part of the newly founded School of Medicine at Arizona State University that just is starting as we speak. So very exciting. I'm excited to be here with you all today. So the title of our talk today is What to Know About Combo IO, a Patient Guide. And the outline of our talk is going to be four things. One, what is immune therapy and why combinations over single agent? Choosing the right combination. The side effects, which we'll learn is a big differentiating factor between the combinations, and what you need to know and when you need to tell your doctor. And then new subcutaneous options that we have for immunotherapy. So to start off, what is immune therapy and why combinations? So immunotherapy in its most general sense is a category of cancer treatment that is just the category of cancer treatment that really tries to evoke the immune system to treat cancer. So any treatment that tries to use your immune system is considered an immune therapy. Most of the time, and most of the current immune therapies that are available for patients with melanoma, where most of these refer to the immune checkpoint inhibitors, which are blockers of immune checkpoints. So what are immune checkpoints? So immune checkpoints are really the natural breaks in our immune system. everyone is born with an immune system, and the goal of the immune system is try to recognize what is you and what is not you. And whatever is not you, your immune system tries to get rid of to protect yourself. The problem is we have billions upon billions of cells in our body. And so no matter how good of a system we have, we're going to make mistakes. And so we have to have backups in there. And one of the main backups are these immune checkpoints, these natural breaks in the immune system. These are the things that prevent every single patient from having autoimmune disease where your immune system attacks yourself. It's also the things that allows people to have to become pregnant and birth children, right? Having a child inside you as part of pregnancy is material that is not yours. Your immune system is trained to attack that. So these natural checkpoints are key to both preventing autoimmunity and then also, helping people get pregnant and preserving babies. So the problem is cancers can co-opt these checkpoints and use them to hide from the immune system. And so these immune checkpoint inhibitors, in terms of treating cancer, really work by cutting these breaks of the immune system. And so for immunotherapies or immune checkpoint inhibitors to work for patients with melanoma, we really need to have the immune system able to identify the cancer. And also, the cancer needs to be hiding from the immune system using these breaks. That is very common in melanoma, which is why immune checkpoint inhibitors work well in melanoma and at higher rates than other cancers. The most common checkpoint inhibitors that we use in melanoma are really the PD-1 antibodies, the programmed death receptor 1 antibodies. And the two most common ones that we use in melanoma are nivolumab and pembrolizumab. So why combinations? So combination immune therapy has been shown to be better than single agent. And that's generally true for a lot of things. More is better. But what is also true is more can be worse. Anytime you add two medications, you may get better response rates. But when you add two medications, you may also get more side effects as well. So we have two combinations that are currently available for patients with metastatic melanoma, and that is nivolumab and ipilimumab, the first combination that we had, and then the more recent combination, nivolumab and relatlimab. And these are actually two drugs, but put in the same vial. So it's one infusion but it contains two drugs, so it is a combination. For both of these studies, these were both approved based on randomized studies looking at the benefit of patients of the combination versus the single agent nivolumab. And so here on the right of the slide, we see two of the kind of what we call Kaplan-Meier curves. And this is for the study that got nivolumab and ipilimumab approved. And what you can see, this was a 3-arm study. It's really small, but the top line, a little kind of yellow-orange line, was patients treated with the combination of nivolumab and ipilimumab. The blue line right below that is patients treated with nivolumab alone. And the line below that is patients treated with ipilimumab, because when this study was done, that was the standard of care. And on the top curve we see is what we call the progression-free survival curve. So all of these lines start at 100%. Every time a patient's cancer comes back, that line drops down. And so you can see that the line of the patients treated with a combination with nivolumab and ipilimumab stays higher than all of the other lines throughout the duration of the study, meaning that less patients had their cancer grow or start to come back after the initial treatment. When we look at the bottom curve, this is a similar curve, but it's looking at overall survival. So all three lines start at 100%. Every time a patient were to pass away, that line goes down. And you can see that in this study, patients who received the combination treatment of nivolumab and ipilimumab lived longer than those who received nivolumab alone or ipilimumab alone. These trends of longer progression-free survival, or less people having their cancer grow again after being treated, and longer overall survival, is the same trend we see with the other combination as well, the nivolumab and relatlimab. And so this really shows us that combination is better at controlling the melanoma. So how do we choose the right combination? Both of these combinations were shown to be better than nivolumab alone, but we've never actually compared them head to head. And a lot of times what we do clinically is we say, well, let's just look at the numbers between the two studies. And if we do that, we see that for the study, CheckMate 067, which got the combination of nivolumab and ipilimumab approved, when we look at the ORR, the overall response rate, we saw that 58.1% of patients had their tumor shrink. Now, we need to put this into perspective. For study purposes, when we say response, we define that as only the patients whose tumors shrink by over 30%. So if your tumor shrinks, but not by 30% or more, you're not actually counted in this. So clinically, outside of a trial, more patients will benefit from therapy, because if your cancer stops growing and never grows again, that's a benefit. But that's not included in these numbers, and that's just due to nuances of how we define things in trials. When we look at the patients who were treated with nivolumab and relatlimab on the study Relativity 067 that got this approved, we see that only 43.1% of patients had their tumors shrink by over 30%. When we look at the side effect rate, which we call the adverse event rate, and adverse events are really any side effects of the drug. And when we have side effects, we grade them based on the severity. There's grades 1, 2, 3, 4, and 5. Really, when we're doing studies, we care most about grade 3, 4, because those are side effects that actually affect your quality of life. If you develop a little itch by your elbow, that is a side effect, but if it doesn't bother you, that's a grade 1, and we don't really count that in the numbers. So grade 3, 4 rate is really what is the clinically bothersome side effect rate. We see for the combination of nivolumab and ipilimumab in the study, there was about a 59% rate of clinically significant side effects. But in the nivolumab and relatlimab study, it was only 21%. So based on this, trying to compare these two things head to head, we think that the side effects of nivolumab and relatlimab are less, but it's probably less effective as well, based on the fact that the overall response rate appears to be smaller. But the problem is when you look at the control arm in both studies, in both of these studies, patients were randomized to combination therapy or nivolumab. Nivolumab is the exact same treatment. And so the exact same treatment should have the exact same numbers if the studies were done in similar patient groups. But what you see is that in one study, nivolumab had a 44% response rate. But in the other study, it only had a 32% response rate. And so we know that we can't compare these studies head to head because the same drug didn't behave the same way, meaning that the patients were different. And so you really can't compare the combinations directly based on these two studies. So what do? We have to turn to fancy statistics, something known as propensity score weighting or inverse propensity score weighting. And what this is it's really an after the fact randomization. So whenever we're trying to compare cancer therapies, most of the time we do randomized studies where patients enroll in a study and a computer randomly assigns you to one or two groups. And the reason we randomly assign people between the two groups is because we think if we randomly do it, the groups will become the same. However, we know that some things in melanoma are really predictive on how someone could do. For example, do you have a history of brain mets? That means you're higher risk. Do you have an elevated LDH protein, which can make you a higher risk? And so when we do studies, not only do we randomize, but we do something called stratification, which is where we mandate the two groups must have the exact same number of patients for markers that we think are most important. And so this propensity score weighting really is that same thing of forcing important differences or important factors to be the same between the two groups. We're just doing it after the fact. And the way you do this is by weighting the patients. We can't go back and change which patients were treated on these studies, but we can weight them differently. So for example, if in one study we had 5 patients with a history of brain mets, and in the other study we had 10 patients, that's an imbalance. That may make those studies look different. How we can balance that out is weighting those patients differently. So in this study where we had 10 patients, we could weight them all at half a patient, which would bring it down to make that the same. We could also weight those 5 patients in the other study as 2 patients or twice as much. And therefore we can balance out that which we know can affect the different outcomes. And if you do that on a patient level through all of these patients or through all of the patients in the study, you can actually make the two treatment groups and the two studies have a similar population. And so here's an example of that, of a picture. So using the statistical methods, if you start with a study here on the left where you have one study, you have the treatment group on the right and then the control group on the left. And you see that you have differences between the two studies, right? So for example, this could be one of the treatment could be one of the combination studies we talked about. The control could be the other combination. And when you look at the patients going up and down, patients on the lower end or lower risk, patients on the higher end or higher risk, you see that there's very much an imbalance between the risks of the patients in these groups. But using that inverse proportional weighting or those fancy statistics, you can actually weight the patients. So some are bigger, some are smaller, and really balance them out as we see here on the right. And that way, when we're looking at the two different studies, we see an equal distribution of both high risk and low risk patients by weighting them differently to balance out the different characteristics. So when we do that, what do we see? The first thing we see is that when we balance the patient populations using the fancy statistics, we see that the nivolumab group has the exact same outcome, which means it worked, right? The same treatment should have the same treatment effect. And after we did the statistical analysis, we see that both groups had a 40% response rate for nivolumab, which tells us that the statistical model was correct. If we saw the outcomes have worsening difference or more difference, then that tells us that the analysis was flawed. But the fact that we made the same thing the same means that it worked. So that confirms what we did. So now, what about when we compare the two combinations after we successfully balance the differences between the two studies? What you see is that both of the combinations actually look better or more close together, I should say. So when we look at the overall response rate for nivolumab and ipilimumab combination, we see a response rate of 50%. When we look at the combination of nivolumab and relatlimab, we see a response rate of 48%. So that's really the same, only 2% different. That's very different than the 14 to 20% difference we saw on the other slide. And so based on this, me and a lot of others believe that really when we're looking at these combinations, their chances of working or controlling the melanoma are probably very similar. But the difference we see is when it comes down to the side effects. And so I've highlighted this here. So when we look at the grade 3/4 adverse event rate, which we said is our clinically significant side effect rate, the rate of side effects that are actually going to bother you, we see that there's about a 60% chance of getting those side effects with nivolumab and ipilimumab, but only about a 23% chance of getting those side effects with nivolumab and relatlimab. So really, once we balance out the differences between these two studies and actually compare apples to apples, it looks like the response rates for these two combinations are very similar, maybe a 2% lower chance of responding with the nivolumab and relatlimab combination, but that may not be real or not. It's such a small difference. But the risk of side effect is much less, almost a third, as compared to nivolumab and relatlimab. So if the side effects are so different, what are the side effects? So we really need to understand the side effects of the immune therapy to really understand if that difference in rate is important enough to help us make a choice between the two. So in terms of the side effects of immune therapy, side effects of immune therapy are very unique. They're not that of chemotherapy. I tell people in chemotherapy, you're on the roller coaster. You get treated, you feel crummy, you get better, you feel treated, you get crummy, and it's this constant up and down. With immune therapy, the side effects can come on at any time. They're not necessarily linked to the time when you get the infusion, like it is with a lot of chemotherapies. And the side effects are unique in the fact that the goal of immune therapy is to evoke your immune system to attack your cancer. So the side effects of immune therapy are evoking your immune system to accidentally attack you. So it's inflammation in parts of the body that are not the cancer. This can happen anywhere in the body, truly anywhere. These drugs can do anything, but they absolutely don't do everything. And I have to remind my colleague physicians of this all the time. I have patients on immune therapy, their nephrologist calls me and say, oh, their creatinine's up, it must be the immune therapy. And I have to remind them, we live in Phoenix, it is 123 degrees today. Did your patient drink enough water? Because being dehydrated is far more likely than the immunotherapy causing that problem, even though it absolutely can. It can do everything, but doesn't do everything. So we always have to look in and make sure it is due to the immune therapy or not. So what are the more common or more serious side effects of immune therapy? The most common three I have listed here up on top. Inflammation of the skin, which presents as rash or itchiness. Incredibly common. If we see this, almost always related. Inflammation of the gut. This can prevent as diarrhea, which is really common, or nausea, which is much less common but can happen. And then also low thyroid. Most of the time, when people are on immune therapy, we are checking your thyroid labs regularly. So typically, we catch low thyroid before it would get low enough that you would ever have symptoms. So that's more of a laboratory test. Less commonly, you can get inflammation of the lungs, which can present as pneumonitis or cough, wheeziness, shortness of breath. Inflammation in the liver, which presents as elevated liver enzymes, inflammation of the kidney or elevated creatinine, and even more rare, probably less than 1% of the time, but more serious, you can get inflammation in the heart, the brain, the muscles, and the nerves. And so another side effect which we have to be on the lookout for is low cortisol or inflammation of the adrenal gland. And I call this one the sneaky side effect because it presents so vaguely. When people get low cortisol, they get a constellation of really vague symptoms. So it can be just this lingering nausea that's just going on for no reason. It could be lightheadedness or low blood pressure or fatigue. I've had patients call my clinic saying, I've been in the ER 3 times the past 2 months. They keep telling me I have the flu. They give me fluids and send me home, but my flu test is always negative. When we say, oh, we got to check a cortisol, it's something you have to think of. I've had patients say, I just don't feel well and I can't tell you why. They come into clinic and my nurse says they kind of look like a ghost. You have to think, is it the cortisol? So anytime you have progressively worsening, evolving, incredibly vague symptoms, this is always the one that we have to think about and test for because it doesn't really declare itself as kind of definitively as the other side effects. So what do you do if you get a side effect? The key is communicate with your oncologist. Side effects for immune therapy are treatable. Most of the time, they are 100% reversible with prednisone, steroids, or other treatment if they are caught early. And so the key is to communicate. So what I always tell all of my patients is if you get a classic side effect, rash, itchiness, diarrhea, call me right away. Don't delay. It's probably related. We'll treat it. We'll move on. Call me if you get any sudden severe medical change. So if you wake up one morning and your muscles hurt so bad you can't move, call us. It's probably not related to the immune therapy, right? That would be very rare, statistically unlikely, but anything that sudden, that severe, we want to ask that question sooner rather than later. And then any mild side effect that's slowly progressing with time rather than getting better, call us. Probably not related, but if it's truly getting worse, we want to know. So the example I always give my patients is if if you're around a bunch of the grandkids or nieces and nephews, they all have cold, you get a cold, 5 days later you're better, probably have a cold, no need to call me. But if you're around a bunch of grandkids or nieces or nephews, they're not sick, and then you get sick, and 5, 6, 7 days later, you're actually getting worse than getting better, that doesn't really fit with a cold. And so if you're truly getting worse, call me. Again, unlikely related to the immunotherapy, but if it's truly getting worse, we just want to ask that question sooner rather than later because earlier treatment typically means higher chances of making it go away and not coming back. So the last topic that we'll talk about is, the new subcutaneous options. So newly approved is a subcutaneous option of nivolumab. So as we talked about with the combinations, both of these are nivolumab based, nivolumab and ipilimumab or nivolumab and relatlimab. All of these are typically 30-minute infusions where you stick an IV in and infuse the medication. In the sense or in the combination treatment of nivolumab and ipilimumab, it's two 30-minute infusions, one for each drug. Recently approved was a subcutaneous, which means an under the skin injection of nivolumab. And this is injected either under the skin in the abdomen or in the thighs only. You need a place where there's, enough subcutaneous tissue or fat that you can actually inject it. And this can be given every 2 or every 4 weeks. The one note with this is approved to be given alone. It is not approved to be given in combination. And so if you are on treatment with combination nivolumab and ipilimumab, that is still approved to be given IV for the 4 doses. But typically with nivolumab and ipilimumab for melanoma, we give 4 doses of the 2 drugs together, and then we transition to single agent nivolumab. Once you transition to single agent nivolumab, then you could do the subcutaneous injection. It's just not approved to be given a subcutaneous injection when you are getting an IV infusion of ipilimumab. This got approved based on a small study looking at but different cohorts of tumor patients with different types of cancer that nivolumab is approved to treat. So that includes melanoma, renal cell, lung cancer, etc. And it was a small randomized study looking at the blood levels, response rates, and side effects of IV nivolumab, so nivolumab given through that 30-minute infusion, or subcutaneous injection of nivolumab injected over 3 to 5 minutes. And what that study showed is it showed similar blood levels, similar response rates, and really similar overall side effects. The study was small, so you can't make too many inferences about it, but it looked the same to maybe slightly less likely to cause side effects, but we can't really make that determination based on how small it was. The one difference in the side effect that we see for the IV nivolumab and subcutaneous nivolumab is the injection site reaction. And that is only seen with the subcutaneous injection. However, that's only seen in 8% of patients and is usually very mild, usually just some mild redness or erythema, nothing significant or severe. Other than that one side effect that's related to just how the drug is given, the studies show that these are very similar in terms of their blood levels, response rates, and side effects. And that is the end of my talk. I think I went a little fast.
Thank you. That was wonderful. Very educational. Okay, next we're going to hear from Sue Capozzi. Sue has devotedly served as a caregiver for her husband, John, who was diagnosed with stage 3 melanoma in 2019, which progressed to stage 4 the following year. Throughout his challenging treatment journey, John has faced numerous hurdles, but is currently doing well. Now retired, Sue and John reside in Little Egg Harbor, New Jersey, close to the beach. They cherish their time sailing, kayaking, and enjoying moments with their friends and their dog, always mindful to apply copious amounts of sunscreen. The couple enjoys the company of their son and daughter-in-law and their 2 young grandchildren, Carolyn and PJ. Thank you so much for being here today, Sue.
Thank you for having me. I hope that I can give people some hope. My husband was diagnosed in the summer of 2019 with stage 3 melanoma, and had his first treatment of Nivo in October of that year. He had 3 of those and had a scan in January of 2020, and he had over 100 tumors throughout his body, liver, lungs, spleen, brain, bones, just everywhere. He was switched, he had gamma knife on his brain tumors twice, and this was all during the height of COVID, so it was quite challenging. And then he was switched to Ipi-Nivo and had 4 treatments of those in 2020. And after the 4 combo, he had 1 single Nivo. And I just want to backtrack. The combination with relatlimab was not approved yet. So that was the treatment that was the standard of care at that point. He is 5 years out. He is doing very well. Each scan got better and better. He currently has no tumors anywhere. He had some of the, Dr. Moser called them the classic side effects. He didn't have any of those. He had the more serious ones. He had a very, very elevated creatinine. It was up to 9. We had very little hope it would ever be normal. It was around 2 for a long time, but at his last scan in April, it was actually in the normal range. So we were pretty amazed by that. He has some residual joint pain from the treatment. I don't know if it's really from the treatment because he's in his early 70s and maybe he's just getting old. And he's giving me dirty looks across the room. But we're doing well. And I hope if I can do nothing else, I can give people who are dealing with stage 4 some hope that things can work out.
Thank you. Thank you, Sue, for sharing your story and for being such an amazing caregiver to your husband, John. And I'm so happy to hear that he's doing well. And it sounds like you have a really great life by the beach. It sounds amazing.
We do. I have to admit, we're a little afraid of the sun. And we don't go out, in the middle of the day, but we do get out there.
Yeah. Well, that's great. Well, we have a bunch of questions coming in, so please feel free to keep them coming. I have a tally. But we're gonna go ahead and start with the Q&A portion. Dr. Moser, I know you talked a lot about side effects. You may have addressed this, but a lot of the questions are about side effects. So are the side effects more serious with the combo immunotherapy? I know that there's different ones, but because when you're doing a combo, is it more, can they be more serious?
In general, the side effects for immune therapy are the same no matter what treatment you get. So if that's single agent nivolumab, pembrolizumab, ipilimumab, or any combination, what's really only different is the chances of getting them. So other than, adrenal insufficiency or adrenal issues, which is incredibly rare, I've never seen it with nivolumab or pembrolizumab alone, you can get any side effect from single agent therapy as you can from combination therapy. It's just how likely you are. So you can get, single agent treatment and still get these really bad side effects like the elevated kidney, or the creatinine and kidney issues that Sue talked about. It's just what the chance is.
Is there combination therapy for metastatic melanoma to the brain?
It's a great question. And the answer is we're still learning. So we know because nivolumab and relatlimab is newer, we're still doing a lot of those studies for cancer that's gone to the brain. We have done a study of nivolumab and ipilimumab in patients with asymptomatic brain mets. So what that means is brain mets that we found on scans that you didn't have any symptoms of. And for patients who have, cancer in the brain that they didn't know was there, they don't have symptoms from, the combination of nivolumab and ipilimumab looks like it works really well. There's about a 55% chance of response, which looks like it's the same chance of benefiting as cancer that's not in the brain. The people who don't have as good of outcomes are the people who have symptomatic brain mets. So people who have vision changes, weakness, numbness, headaches, or other symptoms from their tumor. we know that combination immune therapy and immune therapy in general is less likely to respond. So we may find when the studies are done that the combination of nivolumab and relatlimab is just as good for patients who have cancer in the brain that they don't know is there. We may find it's better or worse, but we don't have that study yet. So most people are still preferring nivolumab and ipilimumab for patients who have cancer in the brain.
Sue, we have a question for you. Is your husband on any therapy now, and how long was he on therapy?
He has had no treatment at all since April 2020 because of the elevated creatinine. But as it went down, his oncologist felt it wasn't worth the risk. But she always said, we have it in our back pocket, and if things make a turn, he could go back on it. But he basically had 3 single agents, the 4 combo, and then 1 more single agent, and then stopped.
Thank you for sharing that. Dr. Moser, I'm going to give you a complicated question here because we've had a lot of people ask about what the best immunotherapy is, or if it works for a lot of the rare subtypes. So ocular, mucosal, and acral have all been asked about. So I'm wondering if you can talk a little bit about immunotherapy when it comes to the rare subtypes and what is recommended and if it works for them.
Yeah, that's a great question. So we don't have as much data on the rare subtypes because we don't typically do studies in those subtypes in general. We kind of lump them into melanoma. But from the data that we have, which isn't, as strong, it does look like the subtypes don't tend to respond to immune therapy quite as well. Now, the caveat to that is if you respond to immune therapy, you will respond just as long as someone who has the cutaneous or more common type. It's just your chance of responding is less. So in general, we think for acral melanomas, mucosal melanomas, maybe the chance of responding to a combination such as nivolumab and ipilimumab might be more like 15 to 20%. For ocular or uveal melanoma, the chance of responding to the combination is probably more like 10 to 15%. So if you respond, you can still respond just as well. And for years, you're just less likely to do so. So we don't know which is best, but because it's a lower chance, I think most of us prefer the combinations. Which combination, we don't really know, but any combination to try to increase the chance of responding is probably important for people who we think are candidates for combination immune therapy and who have a more rare subtype of melanoma, such as ocular, mucosal, or acral.
You may have addressed this as well, but is there one combo therapy that is preferred over another, or is it more dependent on the genetic makeup of the tumor?
Yeah, it's a little bit of a debate right now in the field, and we're mixed. I think for me, I prefer nivolumab and relatlimab for most patients because, after doing the statistical balancing between the 2 studies and making them the same, we saw a very similar response rate between the 2, but a much better safety profile with nivolumab and relatlimab. So I prefer that for most patients, with a caveat that analysis didn't include people with brain mets. So for people who have cancer that spread to the brain, I still prefer nivolumab and ipilimumab because that's where we have data, and we're still waiting for data in nivolumab and relatlimab. And for patients with mucosal and acral, those were so few in the studies, we don't really know. So I tend to go with what we've used before or historically, which is the nivolumab and ipilimumab. But for me, I think that Opdual or nivolumab and relatlimab is a better risk-benefit ratio to most patients. So that's my preference. But there are melanoma physicians out there that say, well, we still see a slightly higher response rate with nivolumab and ipilimumab, and I can manage the toxicity, which is true for most patients. And so there is still some people who prefer that.
Speaking of nivolumab and ipilimumab, I'm sorry, I cannot say that word. I practiced. I'm so sorry. But what is the risk of reintroducing those two after an adverse reaction? And this person put specifically liver enzymes increasing.
Yeah, it's a great question. And so in general, what we think is that if you have a side effect from immune therapy and we treat it and it goes away, and we were to try the same immune therapy, it's probably about a 50% chance that you get the same side effect. So there's about a 50% chance you don't. Now, a lot of that depends on the timing, right? So if you get a side effect, I stop treatment, 2 months later, I treat you again, you're probably higher risk of getting that side effect than if I treat you today, or I treated you 6 years ago, you got a side effect, we held all treatment, and now it's back. The longer you go without reintroducing it, probably the less likely it is for it to come back, but it absolutely still can. If you were treated with a combination and you get a side effect and we decide to retreat you with just a single agent like nivolumab or ipilimumab, probably slightly less chance than 50%, maybe 30 to 40% chance of it coming back, but it could still come back as well. And so the key is if you're going to take that risk, you got to monitor closely. So if it's a kidney issue, you got to be checking the creatinine regularly. If it's a liver issue, the same thing. And you just got to really monitor closely because you know it is risky.
Thank you so much. Great information. We got a lot of questions, so I'm just trying to get them all in. Which is good. We have some time. Is there any immunotherapy treatment available for HLA A-A negative patients?
Yeah, so all of these that we talked about today, these immune checkpoint inhibitors, are not HLA dependent. So in uveal melanoma, there is a drug tebentafusp, which is approved for patients who have HLA-A0201. And so we commonly refer to them as HLA positive patients. That drug, tebentafusp, is currently in a randomized phase 3 study right now in cutaneous melanoma. So it's possible that in the future, if that's a positive study, we will have immunotherapies that depend on your HLA type. But right now, outside of uveal melanoma, all of the treatments and immune checkpoint inhibitors we have are not dependent on your HLA type.
And next question is, are there treatment options available for patients with LMD?
Yeah, that's a great question. So for leptomeningeal disease, which is cancer that hasn't spread to the brain, it's spread to the fluid around the brain, that is a really high risk feature. And it's rare. And so we don't have great data on how to treat that. So I think a lot of people believe that if we see that, we probably need to treat with a combination. We treat it very similarly with other brain mets using nivolumab and ipilimumab. A lot of times if it's just in one spot around the brain, sometimes we'll add radiation. If it's kind of diffusely around the brain, then we sometimes consider whole brain radiation. There have been some clinical trials done at MD Anderson in Houston where they do intrathecal treatment, which is where they do a lumbar puncture and stick a needle into the fluid there and inject either nivolumab or interleukin-2, which is another type of immune therapy that we haven't talked about. Sometimes those can be beneficial. Not a lot of We don't have a lot of data, so it's a lot of just what can we come up with, and that's really the combinations, radiation, and then the intrathecal treatments that were pioneered by MD Anderson in Houston that are available some places. Not everyone is doing those because they are more technically challenging to give.
This is another kind of heavy question, but how often does combo immunotherapy work, and what is the option to use when it doesn't work?
Yeah, so combination immune therapy can be very effective. When we look at the studies of patients who are initially treated on the study of nivolumab and ipilimumab, over 50% of those patients who had metastatic melanoma, newly diagnosed, treated with this combination, are still alive 7.5 years after they were initially diagnosed. So it can work really well. And when you look at those progression-free survival curves, there's about 30 to 40% of patients who are treated with combination immune therapy who seem to never have their cancer grow, or at least not have had their cancer grow again at the 7.5-year mark, which is the longest follow-up we have from the study. And so it can work quite well, maybe 30, 40% of the time. If it doesn't work, it really depends on how long it worked, if it worked at all. And so we know from retrospective data out of France that if you get treated with one combination immune therapy and it works for a long time and then it stops working, that there's actually a good shot, maybe 25, 30% chance that going to the other combination can be effective. But if you have no initial benefit to one combination, then we know that that category of treatment, the immune checkpoint inhibitors, probably are not going to be best for you. And that's when we need to start looking for treatment options that are not immune checkpoint inhibitor based. And so that could be TIL therapy, which was approved last year for melanoma. That could be a clinical trial. You know, we're hoping the FDA is supposed to make a decision on a new virus that we can inject into melanoma next month. If that's approved, then that could be a good option. But yeah.
Still got some questions coming in. And please keep them coming, you know. Is it common to use targeted therapy with immunotherapy?
That's a great question. And I forgot to mention targeted therapy. So for the roughly 50% of patients who have melanoma that has a mutation in the protein BRAF, targeted therapy is also an option if immune therapy doesn't work. We know, though, that immune therapy is better first for people who are candidates for immune therapy. We don't commonly use targeted therapy with immune therapy. There were studies done combining targeted therapy with single agent immune therapy, and it looked better than combination therapy, but it looks better than targeted therapy alone, but we don't actually know it's better than immunotherapy, and it was fairly toxic. About 70% of people had clinically significant side effects. Now, sometimes we do consider it though. So if you have symptomatic brain mets or really high volume disease that we think we need to treat, sometimes people will do that. May do a lead-in where you take a couple months of targeted therapy and then switch to immune therapy. But for most patients, we don't combine targeted therapy and immunotherapy.